It's a lovely good morning and welcome to yet another exciting program, the Lusaka Apex Medical University Radio Grand Round. I'm Stephen Chongompugo as usual. I welcome you to this wonderful, program that you love so much. Remember, you are watching us on Lumen TV and listening to us on Radio Maria Zambia, Lusaka, and also Radio Maria Chipata. And with me in the studios, as usual, I have Professor Taxon Lambert. Mulibwanji.
Nilibwino mauka bwanji.
Tauka Professor.
Omvetsera oyanganira tense mulibwanji mwanse.
I'm sure mauka bwino. So, our dear listeners, this is your program. Remember, at some point after Professor gives us a presentation, so to speak, we are going to open the line so that we can interact with you. So, no, mumvetsele. Akasiza Professor tizasegula mzera kuti mufunse mafunso yamene muli nayo. Wazachita introduce, but before that, Professor, you can do your usual
salutation. I want to bring greetings from our Vice Chancellor, Professor Njeresani, our CEO, Professor Peter Mwawa, our Deputy Vice Chancellor in charge of Research and Innovation, Professor Mulenga, and we have, of course, greetings from Professor John Mudenda, Director of Medical Education, all deans, and indeed our new registrar. Our new registrar is the one who was in the immediate past Deputy Registrar in charge of academic affairs. She's now the registrar. Her name is Madam Sumbwanyambe Likando, and we welcome her into the hot seat of a registrar. As you know, she's the chief administrator of the university. Indeed, all these greetings and the students who are coming back, we have a good number of new students who have already reported. For the new ones, 1,180 already confirmed the reporting. But we are expecting more to apply and to come because we have extended our period to 30th of the month, and even 2 weeks beyond that, we can still enroll because we want as many health workers as we can train under Lusaka Apex Medical University. Today's topic, amazing. God created a human being with all the gifts that a human being needed to have in life. One of them, the central nervous system, the most vital organ is the brain. We did the frontal lobe, we finished. We are now in the parietal lobe. This parietal lobe, you must listen very carefully to what parietal lobe is meant to do and what it does well, and when things are not right, what can happen to the human body. We thank God for this. Coming to Amarumbo Kurilesa, I must say, Towera Nyirongo, the singer, the lady who sang, she's now Dr. Towera Nyirongo, trained at Lusaka Apex Medical University, 7 years, and she has completed her medical training. She's now Dr. Towera Nyirongo.
Wow.
So we want to encourage people, you can combine your talents. She's a talented musician. I was pleading with her, although you are now a doctor, don't stop the gift, the talent you have in music. Try to sustain it as well. But you will practice, you look after people. So we really congratulate. This song is a very, very powerful song. The message is always we should remember to pray. And that's what we are telling our students. You will never have difficulties in life. You put prayer first and hard work. Combine the two. You will succeed in this life and thereafter, after this life. you will succeed. It's prayer plus hard work. So I'm sure people are looking for health workers who are prayerful and hard workers. Thank you.
All right, we can now get into the
Parietal lobe. I think we meant to say this is immediately after frontal lobe. Our students should always remember the central sulcus of Rolando. This is the sulcus that divides frontal lobe from parietal lobe at the back. The sulcus of Rolando, central sulcus. Now, on the lateral side, there's also what we call lateral cerebral sulcus of Sylvius. Sylvian fissure. Some books will write Sylvian fissure. That gives the lateral boundary. And in the midline along falx cerebri, that's where parietal lobe is. Now, on the posterior end, between parietal and occipital lobe, there's the parietal occipital sulcus on each side medially. And if you extend that sulcus, you draw a line, apex, please. Draw a line to the posterior end of Sylvian fissure. Then you will cross what we call parietal occipital notch, and you will have reached the posterior border of the parietal lobe. What is now in the center is the parietal lobe. Immediately after the primary area, what we call somatic sensory receiving area, there's another parietal sulcus, posterior parietal sulcus. That separates the primary area that receives information. Information from every part of the body reaches there for analysis. And when it reaches there, it will spread posterior. So behind that posterior parietal sulcus are what we call association areas to interpret. The sensory lobe, the gyrus, will receive and will pass on backwardly, posteriorly, for analysis. When I'm touched on the leg, the message will say you are touched on the leg. Then the message, but what kind of touch is this? Am I being touched by a cold-blooded animal like a snake passing through my foot? The interpretation must go on. Or where I have stepped, there's a stone which is sharp, it has injured my foot. The interpretation must be done. That's what happens. If it's a fire, it has burnt the toe. The message will go, you have been burnt on your left foot. And the message must be interpreted. Is it hot fire? Is it liquid, hot fluid that has burnt me? That will be sent via the thalamus. And from there, the primary somatic sensory area of the parietal lobe. When it is received, it is passed on backward to interpret. That's why it is there. And then, in the middle of the posterior parietal sulcus, there's the interparietal sulcus, which divides the parietal into two, superior parietal lobule and inferior parietal lobule. Today, we shall dwell with superior parietal lobule because there are a lot of conditions which we want our students to master. A lot of conditions where when you are talking to a patient, you must do a good history, good examination. You will focus and say, is this problem arising from the superior parietal lobule? So what are the characteristics? These are neurons. These are God gift for Adam. And from Adam and Eve we have inherited. By the way, Mr. Chongo, in terms of quantity and quality of the brain, is the same from time of Adam and Eve.
Wow.
It has not changed. Color doesn't mean anything. Your tribal language doesn't mean anything. Your education level doesn't alter the quantity and the quality of the brain. But utilization of the brain, that's where we encourage our students to spend time. Before they reach 30 years of age, they must educate their brains to match up with the standards, global standards, and become internationally demanded health workers. That's what we are aiming at in Lusaka Apex Medical University. So in terms of quantity, the number, the quality is the same. It's a question of exposure to education. Education, education, education. That's why King Solomon said, God, I'm praying for wisdom. And for the first time, God said, you have prayed well. You see, it's about use of the brain.
Use of the brain.
So now, when that brain is located to you, the way we bring up the child, I will give you one good example. When a baby is born, the first reflex is to suck the mother's nipple and grasp the breast. That is the parietal lobe. As the child reaches 2 years, 2.5 years, you find that reflex is stopped by the frontal lobe. That's how they interact. The frontal lobe says, now you are old enough. Don't start sucking your mother. You start withdrawing. That is internally arranged. The interaction between parietal lobe and frontal lobe. Then the parietal lobe itself has got 2 parts. I told you that the frontal lobe, the dominant area for right-handed people is on the left. That we went through.
Yeah.
But for parietal lobe, the dominant area is on the opposite, on the right side. It's on the right parietal lobe. That's the dominant. And there are diseases which can affect the dominant brain. We'll come to that. But the main things that the parietal lobe does are the following. Geographical orientation. We must all know that coming here, I've taken this direction, and to go back to town, I will turn to the right and go to town. You are oriented. That is the parietal lobe, orientation. So in examining patients, Apex, please don't forget the Glasgow Coma scale. We say, is the patient fully oriented in person, space, and time? We are looking at the parietal lobe. I will explain what we are saying. Parietal lobe. So when there's a problem with parietal lobe, a patient will go out of the bed, go to the bathroom. To come back to his or her own bed, she gets lost. That is disorientation in space. If, for example, you are in a compound and the toilet is outside, and the old man goes out, and has a problem with parietal lobe, goes out to the toilet, to come back and be disoriented. And if he has gone out naked, he will go any direction, and he go on. He is lost. He can't find the house. But when people wake up in the early morning hours, they find a naked man, they think it's witchcraft. No, it's disorientation. The parietal lobe is dysfunctional. And you are going to beat an innocent person. It's just the loss of direction. I've told you orientation in space.
The other one?
Or disorientation in time. We always ask a patient, what do you think, Mr. Chireshe, what do you think time is now? He should tell us it's in the morning around 10 hours. He should tell us. That is the part of parietal lobe. Mr. Chireshe, what is your full name? Which address? Where do you stay? We are asking a patient. We are checking parietal lobe function. We also listen to the words that are coming out. Are they appropriate words? If it's inappropriate, we start worrying, is the parietal lobe functioning well or not? 2, the arithmetic, the numbers we use are in the parietal lobe. The gift of parietal lobe. Calculation, arithmetic principles, subtraction, addition. You can ask a patient, look here, Mr. Mlenga, multiply 6 times 6, subtract 5. Mr. Mlenga will quickly, but these days, younger people will go to the phone and start, please. With any belt, use your parietal lobe. 6 times 6, 36 minus 5 is 31. Very good. We know parietal lobe cells are made use of, and they are doing well. So there are certain conditions, even in the superior parietal lobe, dominant side and the non-dominant side. Non-dominant side is geographical orientation, I said. The dominant side, now I'm coming closer to the human body. What makes you, Mr. Chongo, know that this is my left side and this is my right side? I know this left side is a part of me. This right side is a part of me. It's the dominant parietal lobe. Apex, please remember this. It's the dominant parietal lobe. Okay. When there is a massive, there are a lot of people walking around with high blood pressure. One of the damages that occurs with prolonged and treated blood pressure is the damage to middle cerebral artery. And I want our students to master internal carotid artery bifurcates into anterior cerebral artery and the middle cerebral artery. Now, the middle cerebral artery is the main supplier of the parietal lobe. Now, suppose damage by hypertension causes hemorrhage or blockage of middle cerebral artery. The entire parietal lobe loses blood supply. What happens? It means the total dysfunction of that parietal lobe. Therefore, what will happen when it is the dominant side? I told you the right parietal lobe is the dominant side. If it's the right dominant side, the parietal dominant side, there will be weakness, sudden loss of power on the left side. So what happens? There's a total rejection behavior. There will be rejection behavior. The patient will immediately cut off the left side and say, I don't have the left side. You show him this is your left arm. It's weak, but it's yours. He says, no, it's not mine. The feeling has gone because the dominant parietal lobe has been destroyed by hypertension complication, thromboembolic stroke that has occurred, either from the heart thrombus or from the vessel itself. Middle cerebral artery has been blocked. So this is how dangerous parietal lobe damage can occur. So we have looked at the disorientation, we have looked at the numbers, we have looked at the immediate orientation of human body. This is what happens. The mood of the patient can change. You remember when we were talking about frontal lobe, there was also issue of mood. But parietal lobe has also got mood problem. 2, the receiving messages that come through, some of them can be endogenous. I want us to be very clear on that. It's again superior parietal lobe. If it's endogenous, especially in those families that have schizophrenia history, if you hear a Mr. Piri and he comes from a family of schizophrenics, and he tells you, I'm being told to do this, 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 don't take it lightly. That is a very strong indication of schizophrenic tendency, and it may blow up into schizophrenia within a short time. 2, delusions of grandeur. Someone can wake up, Mr. Chongo, can wake up and say, no, I think I'm convinced that actually I'm supposed to be royal family so-and-so. and you start claiming chieftainship of a family which you have never been related to. And if you come from Chief so-and-so, you start saying, but I'm the right one. I'm the right one. And you wake up and say, I'm the right one. And you give trouble. And you are convinced. That is what we call delusions of grandeur. You can wake up and say, I'm actually a millionaire. I'm a multi-millionaire. Even Bill Gates cannot compare to me. That is the Parietal lobe problem. And you can go to the bank and queue up and say, I've come to get 20 million out of 1 billion that you have kept for me. And you start quarreling on the queue. And you are taken to China. Oh, these are delusions of grandeur. So these things do happen. You can wake up and say, I'm the bishop. I'm the bishop of this church. And you walk in front and say, I'm convinced that that is the parietal lobe dysfunction. So things like that should be reported to the health workers. Apex University graduates will be able to pick it and say, this is the problem. Because we are going step by step. We are going to leave no organ, no system untouched. We are going to go step by step. And our students, we want them to be highly qualified, high quality performers in the health sector. That's our dream. That's our prayer. Nikambeko mchinyanja.
Okay.
So lero tilukambaza bongo lapa katikati pa mutu. Pali pansi pali wombo. Mwana kambokula please msampande pali wombo. Ya. Ndiye pali parietal lobe. Pampaja ndiye panga kuti tizwe masamu. Tizi adding 1 plus 3, 1 plus 4 like that. Masamu yachoka kwa menoko. Kuti tilembe bwino, grama ichoka kwa menoko. So ni bwino samala mutu, osapanda pa mutu mwana. Mtiko wopikira osakale wopandira mutu mwana. Please, muchitantumbira mwazi mutu. Parietal lobe singa sevenze bwino. Kuliena machitika ngozi ma accidenti, kaya ma blood pressure, ma sugar problem, tisamale wodwala wotero. Kuti bongo la parietal la pakatikati pa mutu lisaonongeke. Tisamale kuti muntu akale watanzi bwino, aziziva njira yake. Akapita kumunda aziziva kuti njira yo kumuzi ni iyi, asataike. Wachikulire msasie woka, angataiko choka kumunda, alo wa mtengo, aisapita kumuzi, wapita chiyeyeye, angasowe mtengo muja. Ndimo zilili ni bongo, mulungu anatipasa bongo la mphamvu la parietal lobe.
Zikomo kwambiri, Professor. I remember some of you might have been hearing Professor using terms that you cannot understand. This program is meant for both the students and you and I, whom I can call lay people, to understand. That's why the professor is juggling between sophisticated language, terminologies, and simple language. So now it's time for you and us to interact. Yafika ntao yakuti munaise kuti tigurizane mungatume pakuti mufunse zamene mulinazo wa professor wazayanga. Remember, this is the Lusaka Apex Medical University Radio Grand Round, and today we are looking at parietal lobe. In general, we are looking still in the brain. We are looking at the brain. So if you have any questions, this is the time now. People from Chipata, people from Lusaka, people from everywhere where you are getting us loud and clear from, and also people in the diaspora you can call. The number we are using is 0972695200. Yes, 0972695200. Will be more than glad to receive your calls on the same numbers. We have a call. Hello? Hello? Mkwaye mwashuken.
Very good. Nauka mai mwaka bwanji. Inde. Aha. Niziba. Ngati ni one side amai, ngati ni one side chabe, left or right side, amvera iyo numbness iyo, please apimiwe bwino, and chimele chingafunike enso china chopima, nuona ziru chitika mutu, kulitesi kutiti EEG, electroencephalogram, ingatandize, na brain scan, masiku yano maskani tilinayo yalimbwe. So please, apimiwe vonse hivyo, but clinical examination, aeso pima power, masotoni, reflexes, nanga akagwira, ngati ni parietal lobe, timagwira chala cha muntu se, mwaru kambira kuti chinga chiri uku, tigwira chala, uniuze na gwira chala cha kuti, ku left or ku right, nanga uendesa pamwamba hapa, unziwa kuti naendesa pamwamba, uroneza kuti naendesa bwanji. Ngati vonse viruchitika bwino, ala atapo gwiriwa, nakaendede kachala, tiziwa kuti parietal lobe, irutanthauza bwino proprioception. Ni nerves yake ayo. But abwerereso kuchipatala, please akapimiwe bwino. Zikoba mai.
All right, 0972695200, 0972695200. We have another call. Hello?
Good morning.
Morning.
Good morning.
Morning, Professor. Morning.
Morning.
Yeah, my name is Anje Marasmo.
Huh?
Yeah, calling you from Zambia.
Good.
Yeah, I have a problem for the past 4 to 5 days now. Yeah, I've been experiencing a very severe headache, mostly at the back part of my head. And I've been taking some Panadol, but it's not bipolar. So I don't know, I'm suspecting that maybe because nagwapo kumbuyo kunapo anagwapo nakwela kumutu. I'm suspecting that maybe impact na inangena kubreni.
Yes. So, lekani nikambepo pa mutu uwawa, mutu mene tiwopa, mu neurosurgery team. Tiwopa mutu, wamene subwerera ko kumbuyo, upitilizo uwawa kukala wesi. 2, mutu wamene ukambo uwawa, mumvera monga mufuno sanza, olo nusanza. 3, mutu ukambo uwawa, uchitisa chimbuzi kumaso, blurring of vision. 4, ngati mutu uwawa, mumvera weak on any part of the body, ku left or ku right, we get worried with that. 5, ngati mugona nthawe zambiri mugona kwambiri, andi mwina mumajizimuka uuka uchoka kutulo chifukwa chowawa kwa mutu. Mutu wotero utidetsa nkhawa, mungakhale chimene chiri utupa mkati mwa mutu. So it's building pressure, what we call intracranial rise of pressure, and that can be the cause. And ngati mnagwapo, musazengereze, tamangani msanga mupimiwe, and tupironse lipimiwe choka kumutu kafika kumwendo, mpaka chipezeke chiru chitika mutu. Ziko.
All right, Zikomo, we see if we have more calls by 0972695200, 0972695200, ndiye nambara amene tisebenzesa tikuona pa nkani ya brand tiri kwembekeza call yanu pa 0972695200. Hello.
Hello, good morning.
Morning.
Good morning, Dr. Ambas.
Morning.
I wanted to find out, because of late, Madam has been complaining of headache. And Mutoka inangatuwa sometimes it takes time, maybe kapena 2 or 3 days mutuwa wachana. That the problem is a problem.
Alibe vutola blood pressure, alibe vutola sugar.
Oh, it's gone.
Gone. Okay. So kufunika history ya mutu uyo imveke. Kuliye na ma headache yakala ma migraine headache. They are vascular headaches. And as long as the vessels are in spasm, the headache continues. 2, we must rule out. When we say headache, sometimes it's trigeminal neuralgia. Trigeminal neuralgia is the 5th cranial nerve, which can be provoked by dental lesion, by a stoma in the sinuses. We must examine this patient properly and say, what changes on the body functions do appear? So it's history taking, physical examination, including full neurological examination. Headaches should be followed by full neurological examination from head to toe. Then a diagnosis will be made. Ziko.
Okay, Ziko Mokwambiri, we are getting us loud and clear on 99.3 FM Lusaka, and also in Chipata and on Lumen TV. We are listening to the Lusaka Apex Medical University Radio Grand Round. Hello, caller. Hello.
Hello, Lady Maria.
Yes, boss. Bwino mwasenza bwanji?
The professor ncho.
Yeo muli bwanja kulu.
Bwino mukamba na Mr. Mlenga. Calling from airport.
Very good.
Sir, for the past 3 months, I'm experiencing something so complicated and confusing. Last time, I had chicken pox. Body. And then when I went to clinic, in Pachoson clinic, in 5-10 minutes time, I collapsed.
Oh.
And when I could drip, then Penina Gemina Koshasi, I was told that the pressure is too low. So I was given the medicine and everything to stabilize. And then after that, I sometimes experience headache, terrible headache. Maybe for 20 or 30 minutes, it's gone. Clinic, so we kind of a clinic, the person that no, the BP is high. Again, maybe prescription, we are taking an Kalako stable. After maybe 2 or 3 weeks, we are supposed to experience put the same headache. At the end of the clinic, no, the BP is low. So it just goes up, down, up. Now, what could be the problem? Okay.
Very good description. Now, when you had chicken pox, sometimes people react to viral infection, even bacterial infection, by widespread vasodilatation. So, because the vasodilatation is widespread, the circulating blood becomes inadequate, and you check blood pressure, it is becoming low. Suddenly it has reduced. We must check on that one. So what they did at the hospital, very good, our health workers, they put up a drip, and most likely it was normal saline, to fill the vascular system so that there's no hypotension. Because the hypotension can affect the brain itself, the kidneys, and it's very dangerous. That's why he says he collapsed. Yes, that was his sudden hypotension. But it's alternating. Hypotension, followed by hypertension, followed by hypotension. There, what we suspect And he should go back to the hospital and say, my blood pressure is not stable. It's either high or low. One of the things which check is the adrenals. There's what we call pheochromocytoma. Adrenals, they produce adrenaline and noradrenaline. And depending on the amount that are produced, they can, swinging hypertension can develop. So he needs to go back and do a proper history, proper examination, including assessment of the adrenal functions. Thank you.
Thank you so much. We're still getting your calls on the same number, 0979 0979 655200. Hello, caller.
Hello.
Yeo.
Mwauka bwanji.
Tauka.
Balambati mwauka bwanji.
Nauka mfumu mwenye mwauka bwanji.
Balambati.
Ha?
Niliko na vuto. Hello.
Timbera.
Kumbuyo kwa mtu. Nima mbela monga kulema elo kubaba. Sometimes ngatikwa kema nyingi nima mwama nyingi manzi oenda kwa janimbela monga chizwezwe to.
Nanga blood pressure yanu ili banji. Blood pressure yanu ili banji.
Ilibu yino napi misapaka nyama ilibu yino shuga bonse wanapima vilibu yino.
Simna zipeteke kosi. Okay, yeah. Why I'm asking this, Wachongo? Because the nerve supply occipital is pointing at the occipital, at the back of the head. The somatic nerves are from the neck. So when we are examining a patient like that, we shall include the neck examination, including from C1 to T7. T1, of course, for the hands. But from C1 to C7, we must assess. And the occipital part, that's where we shall enter after parietal lobe. So we shall go into detail of occipital lobe when we reach that stage. So I think let him continue listening, and we shall reach the occipital.
Occipital lobe. Okay, we also have another one. Hello, Hello, caller.
Hello.
Yo.
Nine, liko na problem. Mizipe. Nimanzela simizipe kudonsa usiku sinigona bwino iya.
Yoti yamendo okumanja. Yakumendo okumanja.
Yakumendo dina mumukosi. Na mumaribu mulino pesa chiribu china chiboni chachoka chakwela chachitafutu chachoka mzinzake. Ichitogwira po kuti ni chibweze.
Okay, Baza, should I explain?
Yes, I think what is passing through multiple joint problems, maybe with muscles as well. So rheumatoid arthritis is the commonest cause of these problems. Mchinyanja kuti nyamakazi. Nyamakazi chababaya hapa, chachoka, chababaya hapa, chachoka, like that. Nyamakazi. But when you examine these patients, you take good history.
What causes that?
Yeah, that's what I was saying. It's the joints and the muscles and the tendons. That said, that's what causes it. So it's in a group of rheumatoid arthritis. So he needs to go back and give a proper history on how this shifting pain is taking place. Nyamakazi. And they will understand, they will examine and make a diagnosis.
Is it common in...
With age? Yes, it becomes more common with age.
Okay.
Yeah. Sometimes the joints wear and tear, they contribute. But it's better to make a diagnosis. As we always say, old age is not an illness. Because there can be an illness within the old age. So we must make a diagnosis.
Okay. All right, we get another call. Hello, caller. Hello.
Hello,
mkwa mwashuke nakula nshenko.
Mkwa njine kawende tumina kulirai.
Mkwa.
Father.
Niva professor.
Oh, professor.
Ewo.
But when and you know what one thing was a woman one
Amenshi. And then we know a movement menshi nangu indotif. Oh, okay. Okay, they can ask.
Matu.
Numatu machoka man.
Yes. Yes. Very, very important. So, chimeni funo funsa hapa, aziwon woka wakambe, ngati mpuno munali vuto, mpuno. Tukuti rhinitis mchizungu.
Maybe tilaza kutumatu mafuti shukuru wale pushatushena
mpuno muli vuto.
Mwali wakwato wafia. Kutumatu manafuti wa...
Yes.
That.
Of course, if that was the case.
Let's see if it's the one who was called again. Hello? Okay, kutumatu first later on. After I've asked a question. Okay, maybe.
So, yeah.
Let's assume
yes, I'm assuming that because most likely the Eustachian tube apex should remember this. Any ear problem that is discharging, one of the commonest site of problems is in the nose. Pharyngitis or pharyngitis or the inflammation in the nose can block the Eustachian tube. It's pharyngitis. It spreads into rhinitis, into pharyngitis and blockage of Eustachian tube. When it's blocked, in the middle ear, the air gets taken up and fluid starts collecting in the middle ear. And if it's not treated quick enough, it will burst the eardrum and start discharging fluid. That's where I'm suspecting this gentleman. He should be examined, and one of the x-rays they should take is the mastoid air cells x-ray, AP, and the lateral side where it is discharging. The diagnosis will be made.
Mbekache kunyereza but it's problem ani
kunyereza kuja ndiye kuti pressure in the ear is getting less. If Eustachian tube is blocking, the air pressure is getting less, so irritation is trying to remind you that you treat your nose. Treat your nose so the tube is open. If you delay, it will start forming fluid now and getting infected.
Okay, we seem to have a call. Hello, caller. Hello.
Good morning, Professor.
Morning.
I have, I think, first two questions.
Yes.
One, does migraine run in the family? Because then I got a migraine, and sadly, now I'm in the monana over one history. Then, Chimbi, I have a history of raising pressure. No, but lately, don't follow in Shingwa. Like last year, I got in Shingwa for 5 months. Linked to Shafi. Bampako, Stella, Tajiron, Tiufilia. Now, Pako no Pano Fukian. And I sat and Poko form to number. Uyom to Ukaipa place. Place Tuko. Ngawatampo Ukari, Uapati, Ule Donsa Maso. So Ngayatampo Donsa Fila Funga, and Fiat and the Pampan Chocolate Station, Chile Keko. Then for it to start again and it will pull the neck just on the left side. Now I'm thinking, because first you're not quite raising the pressure. Pakutampo mtono wala tampana leo mtoka tumuto mwaenda makokrochi. And then I started fitting. So my sight went wrong and everything else. But when they did the MRI, that's when they said I had a raised intracranial pressure. Now my worry is, you must know how to they can left tupu. No, could on some veins, mama nerves on the neck and so forth. Where is it leading to? What could that be?
Thank you very
Alright,
much.
Thank you so much.
She has mentioned so many important points. Is the migraine familial? Yes,
hereditary.
familial tendency is there with migraine. Because it's the vascular spasms that occur. And it can be unilateral or bilateral. 2, she has said that when they did MRI, it has shown that there is raised intracranial pressure. We must find out what has raised intracranial pressure. Because the finding is that it's an indication that there's something which is causing it. We should find out. 2, she was feeling things moving on the head.
Like cockroaches.
Yes, like cockroaches and all that. So parietal lobe is getting involved. What is it saying? What is it telling the human body? What's going on? And this one side. So we must check parietal lobe on the both sides, dominant and non-dominant areas. Very, very important. And a number of triggers which are causing this. But I'm just advising she needs a thorough history-taking, physical examination, and the proper investigation. That the MRI gives us a physical picture of what is going on. But the EEG gives us a functional element of it. Electroencephalogram should be done. Compare the right and the left side, where parietal lobe especially is. Thank you.
All right. We have another one. Hello, caller. Hello. Yes.
Professor Namakusa, you can come
Inde.
Namakuso atakola video.
Mukareko first time?
Yo yamba funzo yangoti ngati ngamuna kukumana na mkazi then wapata imejo chani kuvira mavenzi yababa mchani and number 2 umavera kupcha kwa abdomen kupcha tunasolo ya kufunda patini moto vuto ni chani na number 3 i problem ikana kutosa mpavu yokwanira ya mwamuni.
Aha.
Okay. Ziko mkwambi.
Yes. I think for him, we should check genital urinary tract. Genital urinary tract. Makamaka ya number 3, ingatsegule vambiri. Tiwone mpamvu ya chamuna iruchepekera. Ichiru chitika nichiani. So we must take testicular function, including testosterone examination. We must also check the prostate itself. How old is he? How is it performing? What about urinary frequency? Things like that. We must go into genital urinary system. And the kupya kumenakamba huku. That's the nerves now. The hair. That's the nerves. We must locate the dermatomes which are involved. Is it T12? Is it T10? Is it T6? Is it T4? We must assess and find out what is happening. Kwa kuchinyanja tikuti umanena chatsitsa zae kuti njovu itoke mnyanga tochifunikira hapa.
Okay, we can get 2 or more calls before we close on 0972695200.
Iwambuye banu uchipata shuwemu.
Muzi watu mesako airtime. Mama mbela bwino kuingo mvesera maningi. Mvesera maningi. 0972695200. Those are the numbers that we are getting. Now, okay, we have one. Hello?
Hello, Mauka.
Tauka. Otauka mama.
Niko na problemu kudala nizombelako kumutu kwenzolira chiki manja hapa nalekako problem manje namba kumanja yonse yabiri kumwezi zimakosa then nakupwanya maningi ngangale problem bwanje.
All right,
very good.
Azaya nkaziko.
So vijana papo yamba panja, it is a part of the parietal lobe. It's trying to interpret something. Some things are making noise. Now, when he comes to a hospital like she comes, we must say, is it tinnitus? Or is it something she's feeling but which is not real? Unreal, you know. What about the scalp itself? That is the first part we must assess in relation to parietal lobe. Because whatever we feel on the body, it has to go first to the parietal lobe. Receive and spread and interpret. That's why God gave us this particular part of the brain. All of it must pass through the thalamus. The thalamus, which I said the first anatomists thought it was the bedroom of the brain. That decisions are made in the thalamus, not knowing just a transit point. The higher centers are the ones that deal with decision making and interpretation.
Okay.
So that's why. The last part she was talking of which part?
Wow, does ever.
Yeah, but it was more about these on the head movements. But next week she may repeat to see the part 2 of her question.
And also, so what you can advise her and the other person who had problems in abdomen and to go to the clinic.
Yes, must go back to the hospital, see a health worker, and explain what is happening, and we should find out what is going on.